discuss the third station of the pathology for MRCS Part B, and that is temporal arthritis, also called giant cell arthritis, and we will be also discussing the osteoporosis. Okay, so temporal arthritis and osteoporosis. So what is giant cell arthritis? It is basically the granulomatous inflammatory disease of the blood vessels, mostly large vessels, or it can be medium vessels of the head, mainly the branches of the carotid artery, not just external carotid artery. It is the branches of the common carotid arteries, like it can involve the external carotid artery as well as the internal carotid artery. Okay, so which part of the vessel is most affected most? So the tunica media layer of the vessel is mostly affected by the giant cell arthritis or temporal arthritis. Okay, so what will be the clinical features? Okay, so the clinical features of the the giant cell arthritis, as it involves the branches of the common carotid artery. It can be external carotid artery or internal carotid artery. Okay, so when it involves these branches, so the clinical features can be unilateral headache, it can be temporal artery tenderness, because there is inflammation of the temporal artery also, so that's why it is also called temporal arthritis. So temporal artery tenderness, and there can be jaw claudication due to involvement of the ophthalmic artery, causing the ischemic optic neuropathy, so it can present as the blindness. Okay, so these are the clinical features of the giant cell arthritis: unilateral headache, temporal artery tenderness, jaw claudication, and blindness, which can be transient loss of vision. Okay, so that's the clinical features of the, and it affect mostly the females. Okay, it affect mostly the females greater than 50 years of age. Okay, so that is giant cell arthritis. Now describe the pathological changes in the microscopic picture. Okay, so that is the microscopic picture of the given, and there is the giant cell arthritis involves the arterial segments to develop intimal thickening with occasional thrombosis that reduces the luminal diameter. Classic lesion exhibit medial granulomatous inflammation centered on the internal elastic lamina that produces the elastic lamina fragmentation. There is infiltrate of T cells and macrophages. Although multinucleated giant cells are seen in the approximately 75% of the adequately biopsy specimen, granulomas and giant cells can be rare or absent. Inflammatory lesions are only focally distributed, okay, along the vessel and long segments of relatively normal artery. Okay, so it causes basically the giant cell arthritis is the focal granulomatous inflammation. Okay, so it is focal granulomatous inflammation. Okay, focal granulomatous inflammation. So in this microscopic picture you can see, okay, you can see the giant cells near the fragmented elastic membrane. Okay, so these are the giant cell near the fragmented internal elastic membrane. Then in this picture B you can also see the destruction, you can see the destruction of the internal elastic membrane. There is focal destruction. Okay, so this is focal granulomatous inflammation. Then there is one blood test will show the giant cell arthritis inflammatory process, and that is ESR, erythrocyte sedimentation rate. Okay, and it will be elevated in the giant cell arthritis. Then the most confirmatory test are the investigation of choice is temporal artery biopsy. Okay, but before biopsy, give high dose of steroid. Why? Because it can lead to irreversible blindness. Okay, so due to risk of blindness, we must give high dose steroid before temporal artery biopsy. Okay, what is most important complication? So already talk about it is blindness. Then why blindness? Because of the involvement of the ophthalmic artery, which gives retinal artery and artery. Okay, so it can cause the ischemic optic neuropathy. Okay, ischemic optic neuropathy, ischemic optic neuropathy. Then how we will treat this giant cell arthritis? So the main treatment is steroids. Okay, glucocorticoids, also known as corticosteroids. Okay, so the corticosteroid is the main treatment option. First we will start the prednisolone 60 mg per day per oral. Okay, immediately, or IV prednisolone if evolving visual loss or history of MRCS fugax, and this corticosteroid will be given for 2 years. Okay, 1 year later patient develop fracture neck of femur. Why? So it can be due to avascular necrosis and osteoporosis. Okay, so as it involves the mostly females at the age of more than 50 years. So in the old age the osteoporosis is very common. Okay, and as as it is common in female, so in the female, in the more than 50 years female, there is postmenopausal period. Okay, in the postmenopausal period there is low estrogen. Okay, low estrogen level, so it can also lead to osteoporosis. And in the giant cell arthritis, the main treatment is corticosteroid. So the corticosteroid can lead to avascular necrosis and osteoporosis. So that's why the patient can develop osteoporosis and avascular necrosis, and that's why she can develop fracture neck of femur. Okay, so why osteoporosis in this patient? Which patient? In this patient the scenario is given 60-year-old female. Okay, with headache, temporal pain and skull tenderness on mastication, transient loss of vision. So these are the clinical features of the giant cell arthritis: the unilateral headache, the jaw claudication and blindness. Okay, Biopsy from the temporal artery revealed giant cell arteritis granulomatous panarteritis with mononuclear cell infiltrates. Okay, so in this patient you can see the age is 60-year. This is old age female. So in the old age female, the osteoporosis has many reason. Like the patient is taking steroid therapy, so due to steroid, she can develop the osteoporosis. Okay, so due to steroid therapy, she can develop the osteoporosis and avascular necrosis. And postmenopausal woman, as the age is more than 50, so this is postmenopausal, in which there will be low estrogen, decreased estrogen, which can lead to osteoporosis. And age related osteoporosis can also occur in this patient. Okay, age related osteoporosis. Okay, so the osteoporosis has many causes, like osteoporosis, causes of osteoporosis. It can occur in old age. So old age is one of the cause of the osteoporosis, age related osteoporosis. Then postmenopausal woman, due to low estrogen, postmenopausal female. Okay, so postmenopausal female due to low estrogen. Then it can be due to drugs like steroids. It can be due to bisphosphonate. Okay, sorry, not bisphosphonate. Bisphosphonate is the treatment for the osteoporosis. So it can be due to steroids, the anticonvulsants drugs, anticonvulsants. Okay, so these are the, it can be due to condition like hyperparathyroidism, multiple myeloma. Okay, so multiple myeloma, hyperparathyroidism, and hyperthyroidism. Okay, it can also occur in anorexia. Okay, so these are the causes of the osteoporosis. And the main thing in the osteoporosis is that there is decreased bone mass. Okay, cortical and spongy bone mass will be reduced. Okay, so reduced bone mass is the main pathophysiology in the osteoporosis. There will be normal bone mineralization and normal serum calcium and phosphate. Okay, the phosphate and serum calcium will be normal. Okay, but there will be decreased bone mass. Okay, so this is about the osteoporosis. So pathological changes in the osteoporosis. So as I mentioned before, that there will be histologically normal bone, that is decrease in quantity, so decrease in bone mass. Postmenopausal osteoporosis is the increase in osteoclastic activity, which affects mainly bones or portion of bones that have increased surface area, such as the cancellous compartment of vertebral bodies. The trabecular plates, okay, the trabecule becomes perforated, thin, and lost their interconnection leading to progressive microfractures and eventual vertebral collapse. So in the osteoporosis, there is fragility fracture. Okay, in the osteoporosis there is that fragility fracture, which mean the fracture from minimal trauma. Okay, fragility fractures, the fracture from the minimal trauma in the hip region or vertebra region. Okay, so the next question is, what is osteoporosis and what is its pathogenesis? Okay, so osteoporosis and its pathogenesis. So osteoporosis is metabolic bone disease characterized by low bone mass, microarchitectural deterioration of the bone tissue, increased bone fragility, loss of bone matrix. But you can remember there is normal bone mineralization, but there is low bone mass, normal bone mineralization. Okay, so this is important in the osteoporosis, that there will be normal bone mineralization. Okay, three mechanisms in the pathogenesis are inadequate bone mass, excessive bone resorption, and inadequate formation of new bone during the bone turnover. So these are the mechanisms which can lead to osteoporosis, and all these mechanisms are driven by the increase in osteoclastic activity. Increase in osteoclast activity. Okay, so this is the main mechanism which can cause the inadequate bone mass, excessive bone resorption, and inadequate formation of new bones during bone turnover. Then the mechanism by which corticosteroid cause osteoporosis. So there are many mechanisms. The first one is this. Okay, direct inhibition of osteoblast formation, direct stimulation of bone resorption. Okay, bone resorption. Then the inhibition of GIT, calcium absorption. Okay, then the stimulation of renal calcium losses and inhibition of sex steroids. So these are the mechanism through which the steroid can cause osteoporosis. It directly inhibit the osteoblast formation, directly stimulate the bone resorption, inhibition of GIT calcium absorption, stimulation of renal calcium losses. Okay, and inhibition of sex steroid. Then causes of osteoporosis, I have discussed it before. It can be primary or secondary. Primary can be idiopathic, postmenopausal, and senile, which is age related. Okay, age related. Then the endocrine disorders which can lead to the secondary causes of the osteoporosis can be endocrine disorders like Addison disease, diabetes, hyperparathyroidism, hypothyroidism, pituitary tumors, neoplasia, carcinomatosis, multiple myeloma, gastrointestinal, hepatic insufficiency, malabsorption, malnutrition, vitamin C and D deficiencies. Then the drugs which cause the osteoporosis: alcohol, anticoagulants, anticonvulsants, chemotherapy, corticosteroids, and miscellaneous causes can be anemia, homocystinuria, immobilization, osteogenesis imperfecta, and pulmonary disease. So these are the primary and secondary causes of the osteoporosis. Other causes of the pathological fracture. Pathological fracture is also known as fragility fracture. Okay, fragility fracture. Pathological fracture causes can be skeletal metastasis, Paget disease, multiple myeloma, rickets, osteomalacia, osteogenesis imperfecta, and radiotherapy. So these are the causes of the pathological fracture. Now the multiple myeloma. What is multiple myeloma? So multiple myeloma, it is a plasma cell neoplasm commonly associated with lytic bone lesions. Okay, the first is, so it is basically the plasma cell neoplasm. Then it is associated with lytic bone lesion, hypercalcemia, okay, renal failure, and acquired immune abnormalities. It produces large amount of IgG 55%, IgA 25%, okay, and it can also produce immunoglobulin light chains, okay, immunoglobulins light chains. So the most common are the most common antibody produces IgG, then IgA, and then the Ig immunoglobulin light chains. Okay, it is most common. It is most common primary bone tumor in elderly. Okay, so it affects elder population mostly. Okay, more than 50 years or more than 60 years of age. Okay, how we will diagnose it? Okay, so diagnosis can be we can do the x-ray, and in the x-ray we can see the punch out lesions on the x-rays. Okay, punch out lytic lesions on x-ray. Then on the protein electrophoresis there will be M spike. Okay, M spike on protein electrophoresis. On the urine analysis, in the urine analysis there will be Benz-Jones protein, which is immunoglobulin light chain. Okay, so Benz-Jones proteins. On the urine analysis we can see these. Then we can also do the bone marrow biopsy. Okay, so these are the first is x-ray, then protein electrophoresis, then the urine analysis which shows the Ben-Jones protein, and the other thing is bone marrow biopsy. Okay, bone marrow biopsy. Okay, so the bone marrow biopsy can show the more than 10% of monoclonal antibodies. Okay, more than 10%. Okay, %10 of monoclonal plasma cells. So the bone marrow biopsy is one of the investigation. Now the through the clinical features we can also diagnosis. So the clinical features we can remember by this mnemonic, which is CRAB. So C for hypercalcemia. Okay, hypercalcemia, corrected calcium more than 2.75 millimole or more than 11 milligram per deciliter. Then the R is for renal insufficiency attributable to myeloma. Okay, then there is anemia. Okay, and the fourth clinical feature is lytic bone lesions. Okay, bone lytic lesion. Lytic lesion or osteoporosis with compression fracture. Okay, so the clinical features of multiple myeloma. It can be remembered by CRAB, C-R-A-B. Hypercalcemia, renal insufficiency, Okay, A for anemia and B for bone lytic lesions. So these are the four main characteristic features of the multiple myeloma. Okay, clinical features of multiple myeloma. Then what is Benz-Jones protein? Okay, so we already discusses that it is immunoglobulin light chain. Okay, immunoglobulin light chain, they are monoclonal globulin proteins or immunoglobulin light chains. Okay, found in the urine. The protein are produced by the neoplastic plasma cells. Benz-Jones protein are present in 2/3 of multiple myeloma. Okay, then the concerns if going to surgery. So concern if going to surgery is Addisonian crisis, because it is about the previous scenario. Okay, this scenario in which the 60-year-old female was has giant cell arthritis, and she was using steroid for that. So a person on steroid, if they go for surgery, and if there is like if we stop the steroid, then there is a risk of Addisonian crisis. Okay, there can be risk of Addisonian crisis in which there is decrease cortisol level. Okay, cortisol level. How to prevent the Addisonian crisis in this patient? So there will be two things we can do to prevent the patient to go in Addisonian crisis. Increase the patient's steroid dose prior to the surgery. Okay, increase the patient's steroid dose prior to the surgery, and then convert it to the hydrocortisone. Okay, so these are the two main things to do before surgery to prevent the Addisonian crisis. Okay, the question is, the patient went for total THA, total hip replacement, died in post-op day 1, suddenly cause is fat embolism. Okay, for fat embolism, causes of fat embolism, the first is long bone fracture, major burns. The second cause, acute pancreatitis, diabetes, orthopedic surgery, intramedullary nailing or joint reconstruction, decompression sickness, and cardiopulmonary bypass graft. So these are the causes of the fat embolism. Now how to manage the patient with fat embolism? So mainly there will be supportive and prevention of complication like acute renal failure. Okay, and ARDS. We can give the respiratory oxygen, mechanical ventilation, fluid and electrolyte balance. Okay, and general measures like to prevent the DVT, sepsis and nutrition. Then the specific is unproven ethanol, dextran and heparin. So these are the steps through which we can manage the patient with fat embolism. Okay, temporal artery arthritis we have already discussed. There will be there can be ophthalmic artery involvement, which gives the irreversible blindness. Okay, and we will use the corticosteroid. First, the prednisolone or IV methylprednisolone if evolving visual loss or history of amaurosis pubis, pathological fracture due to osteoporosis or avascular necrosis. Okay, so I think we have discussed all of them. Okay, so in the next section we will discuss the gangrene and mesothelioma. Okay, the gangrene and mesothelioma in the next lecture. Thank you.